Welcome to Newsnight. I'm Lanre Lasese, and thank you for joining me. Tonight, we focus on an issue often overlooked, yet silently devastating millions of Nigerians. It's a health challenge that cuts across age and gender, draining families emotionally and financially. I'm talking about the cancer epidemic. This silent disease continues to claim lives while exposing the gaps in our healthcare system. On the program tonight, we'll examine its impact, Nigeria's response, and the urgent steps needed to confront it head-on. Joining me tonight is the Director General and Chief Executive Officer of the National Institute for Cancer Research and Treatment, Professor Usman Malami Aliyu. Thank you for being our guest today.
It's my pleasure to be here.
I would like us to start from the top. I'd like you to please explain to us what the National Institute for Cancer Research and Treatment, what's it all about?
Correct. So the National Institute for Cancer Research and Treatment, NICRAT, is an agency of the federal government under the supervision of the Federal Ministry of Health. That is in charge of cancer control in the country. So when we say that, we mean all the activities that are geared toward cancer control in the country resides in the agency. And looking at the continuum of care that we are talking about, which the agency covered, extends from or starts from cancer prevention, early diagnosis, cancer treatment, cancer research, cancer survivorship, and palliative care. So the institute covers the whole continuum. So anything that concerns cancer control in the country, mitigating the morbidity and mortality, and in short, the scourge of cancer in the country, it is the responsibility of this agency that is established by the federal government. You know, before now, there was actually no agency in charge of cancer control. It's only a unit or desk office in the Federal Ministry of Health. But because of the rise, the continuous increase in the incidence of cancer, or generally, if we can say the burden of cancer globally, so that actually necessitated or mandated the federal government, out of the goodwill of the government, to have an agency that will help the country in mitigating the problems that this dreadful disease is trying to push to the country. You know, we have limited resources, you know, in the country. Infectious diseases are ravaging African continent, if you look at it. And now, recent projection by the scientists and World Health Organization shows that currently we have world over, we have there about 20 million new cases of cancer. And they projected that the incidence of cancer will continue to rise unless and until the world do something about it. And it was out of that, you know, and what is most scary, I always used to say that almost 75% of this increase is going to come from the low and middle income countries. And we know where Nigeria lies. Africa, the whole Africa lies within the low and middle income countries. And so also Nigeria. So, and in Africa, we are the largest, the biggest economy, the largest in terms of population and whatsoever. The recent statistic from the Globacom, which is a subsidiary of World Health Organization in charge of record or statistic on cancer, indicated that the burden of cancer in Nigeria constitutes about 10.5% of the whole Africa. So if you look at that, you know that Nigeria is struggling with the largest burden, you know, of cancer in Africa. We are among the three that are sharing the greatest burden, Nigeria, South Africa, and Egypt. But Nigeria is the country that is leading. So something must be done. So the government of virtually all the African countries, the world, and the African country must rise to the occasion. So we have to commend the government of Ahmed Bola Tinubu, His Excellency GC ON, for standing tall and ensure the establishment and the support of an agency that is purely meant for cancer control. And we also have to commend the effective supervision and support we are getting from the Prof. Ali Mohammed Pate, who is the Coordinating Minister for Health and Social Welfare, and also Dr. Isiaq Adekunle Sadako, who is also the State Minister for Health, who are supporting the agency immensely to ensure that we deliver on the mandate given to us. We have an elaborate mandate.
Yeah, very elaborate, and I want to pick up on that mandate. But before we go to this agency is a young agency. So you are indirectly putting the building blocks of almost everything we're doing so far.
Yes.
So when it comes to the issue of policy, what has been the way you've gone forward on that?
All right. So thank you very much. The Institute, as you've just mentioned, it's a baby agency, just 3 years old. In our first year, we concentrated on building agencies that can stand the test of time, that will address the peculiarity of cancer challenges in the country.
Okay.
And it was actually from there that we drafted the first, what we call the National Cancer Control Plan. That is 2023 to 2026. So we drafted that. That's the first policy. And it's like a guide to what we're going to do from the year 2023 to 2026. We also drafted cervical cancer elimination guideline, which is, and also a cancer research agenda. These 3 documents were actually drafted in the first year, and they really help in guiding us. But as we go forward, and our Western colleagues organization, in the West, the International Atomic Energy, the World Health Organization, and the International Agency for Research on Cancer saw the commitment of the agency and now the government. Now they assisted the country to do what we call an impact review, which is a general assessment on the strengths and weaknesses of the country toward fight against cancer. So when we did that, and it was actually the institute, the government of the country, with their support that, sponsored that, we were able to go around the 6 geopolitical zones in the country. We assess virtually from primary healthcare centers, general hospitals, and the teaching hospitals to assess the strength and our weaknesses. And the report is currently out. So after the report came out, we now sat and review our plan that we already drafted, and we realized that we have some certain gaps that were not covered ab initio. So what we did was to review the NCCP to capture those areas that we actually need to strengthen more. So we included them, and just last year, so the last quarter of last year, we launched a reviewed version of the National Cancer Control Plan that we are currently implementing of. So you can see we have this document, and whatever we are doing now currently, we are following what is in the NCCP, because that is what aligns with what the other countries elsewhere are doing.
But it's also adapted to our own peculiarities.
Yes. Yeah.
Okay.
So that was what we did. We, I've mentioned that.
Yes.
It was, the document is ours.
Yes,
and
yes.
we actually built on it. The only thing is we had an input from these people, the World Health Organization, International Atomic Energy Commission, and IRAC. And then we tailored it to suit the peculiarities that we currently have in the country. Of recent, if you are aware, the Institute, with the backing of the Federal Ministry of Health, established what we call the national, and also the support of Her Excellency, Senator Oluremi Tinubu, established the National Task Force on Cervical Cancer Elimination. You know, the whole world, under the guidance of the WHO, is trying to phase out cervical cancer to eliminate it by the year 2030. So the Nigeria key into that with the support of the First Lady by donating a seed money of 1 billion. She championed that and she donated that, which actually assisted the agency and the Federal Ministry of Health and the whole country in the fight against cervical cancer. We have launched the process of cervical cancer elimination programs in Owerri, Imo State. That was where we flagged up the launch in the scale of, maybe you were not, you were following, you will see us there, where we got the support of the governor and the First Lady, the chairperson, First Lady Against Cancer, which is Barrister Chioma Hope Ozadimma. So she were there. And then the next state we are going is Niger State. So we are gearing up, trying to see that we actually flag up this screening and treatment program in all the 6 geopolitical zones in the country.
Prof, you know, the little I read about this, it makes it look like it's a growing concern, and one that a lot of people may not be aware of, except you have somebody that, you know, even though you some people say you are hearing it more than you used to hear, you hear this person has or you hear somebody had. But you've sat now, you've looked at the country. What is the situation? What's our own, how does it look from your own perspective?
Correct. So generally, just like what we are currently seeing, the look is not different from what the other countries in the world, what the picture is compared to I mean, in the other countries, you know. The incidence is rising of cancer generally in Nigeria, we all know, and just like in other places. But what we are expected to do is to come out with more strategic solution on how to mitigate not only the rising, but the burden. The rising is a double-edged sword.
Okay.
Sometimes you will see an increase in the incidence if you improve your screening programs.
Okay, so I get where you're going now. So let's take it one at a time. We're not talking of prevention now. We've gone to screening.
Okay, maybe I can. Okay, finish.
You understand? I'm saying yes. From the picture you are seeing now, you are saying you've touched on the issue of screening.
Yes.
And you are saying that if we do the screening, we might get more numbers than what we have.
Yes. So because, you know, screening, when we say screening is part of prevention, you know, we have 3 levels of prevention in cancer care.
Okay.
The first level of prevention is health education.
Okay.
You know, you improve the health education among the populace out there. You know, some people are not aware that even cancer exists. Some are saying it's witchcraft, you know, if you meet them. And there are so many erroneous things that are out there. So you have to have, you know, informed people that this is real. Of course, it has the reason why it affect one and maybe probably leave the other? What are the common causes? What are the risk factors that exposes one? So that is one. You have to ensure that you educate people so that they know what causes the cancer. So if possible, they can stay away from it, whatever it is. Now, the second one is the screening, where the screening comes from. It's the second level of prevention.
Okay.
You screen, vaccinate.
For those that have...
Yes. When you screen, the ideal thing is you go into the population. The people that are normal, in the community, the otherwise normal people, they are not aware that they have cancer, whatever. You screen them. Now, in this group of people, if you are to find some to come positive with that cancer, they will come with an early, either precancerous lesion or at stage 1 maximum, that you can quickly treat and cure them.
Because I need us to emphasize some things, because when you don't know about something, it becomes more dangerous to you.
Very true.
Ignorance makes things look really bigger than they could possibly be.
Yeah.
And there's this, and I think you mentioned that when you say some people are also worried about going to do this screening. You go and know what you didn't know before. That now becomes a burden.
Yeah.
But when you talk of it can be treated, it makes it look like that's not the notion out there. A lot of people believe once you hear somebody has cancer, it's a death sentence.
So actually, it's not true. Cancer is a disease that can be cured. Our major problem is late presentation.
Okay.
If you present late, cancer has 4 stages. Stage 1, stage 2, stage 3, and stage 4. Stage 1, and in some cancers, even some stage 2 are considered early presentation. 2, 3 are called locally advanced disease. They are advanced, but they have not spread in the body. Then we have stage 4, the stage that this cancer has already spread in the body. If you present only very few cancers that we know currently that can be cured at that 4th stage. Otherwise, once it has spread in the body, it's palliation, wherever you go in the world. So that is that. But if you present early, and that is why we are investing more on prevention, because if we improve the awareness of the community on what causes this cancer, people will have a modification in their lifestyle and more changes or modification in that lifestyle would now decrease their chances, the risks of them getting that cancer. Now, second, because they are used to doing what they have stopped doing now, they were exposed. So we now go ahead and do the screening. Now you may screen like 10, and out of 10, maybe only 1 will come up with some changes that could lead to cancer. Instantly, currently what we are doing, once we detect that, we have drugs that can offer an immediate intervention that can confer cure, on that lady. So that is, once we do that, we are rest assured that we have treated her cancer. Yeah. But on our system, we will record her as positive. And annually, when we come to present the statistics of cancer in the country, we'll add her.
Yes.
Unlike if we now maybe probably go into that community to screen. So that is why I'm saying that it's a double-edged sword. Sometimes you improve screening programs, and so the incidence and the statistic will go.
And not because it is costing you, but because you are just finding out.
But because you are finding, you are doing more. And so maybe people will have to have that at the back of our mind. So through that, currently, our plan that we have laid out is to go through the 6 geopolitical zones. and ensure that we have launched this very good initiative on that cervical cancer, that we have a very good support of Her Excellency Senator Remi Bonatinubu, that is supporting, and also the flag, the First Lady, and even the wife of state governors from are really assisting. So that if we launch it, we will teach people, the healthcare workers, on how to conduct this screening program, on how to, the importance of taking vaccines, and where to get those vaccines. So that is why, so that virtually by that 2030, that the WHO will actually be celebrating elimination in some states. At least we could reach up to there about 50%, reduction in that, because we started ours just last year. So we are not hoping to say we've eliminated, but at least we're going to.
And that's for cervical.
That's for cervical cancer.
Cervical cancer. From what you know, which ones would you say are the most prevalent in Nigeria?
Okay, so in Nigeria, the most prevalent is the breast cancer, followed by cervical cancer, then prostate cancer in male. We also have colorectal cancer, and then non-Hodgkin's lymphomas.
Sorry, I didn't get that.
Non-Hodgkin's lymphomas, the lymphomas, yeah, which are mainly blood cancers that can turn into, a solid tumors that can be seen somewhere.
Now, when you come to the issue of screening, because I know you do policy, and for all of us, what makes us stand out is our population. I'm not sure how your advocacy, because that's what you still call it, falls under advocacy. Yeah. How does that transcend, or how does that trickle down from the federal to the rural area?
So generally, if you look at what I've just mentioned, the issue of generally cervical cancer elimination, we started at the federal.
Yes.
And then we now cascaded it down to the states.
Yes.
And the discussion that we are having now is from the states. They are going to now push it down to virtually the primary healthcare centers.
So you're working with the states, subnationals?
Yes, we are working with the subnationals.
Okay.
Initially, when we started during our first year, we embarked on training the primary healthcare workers, the nurses, to train them. What we did first was to do an environmental scan. An environmental scan will tell you what are the common cancers that you have, like in the southeast. What are the common cancers that you have in the northeast?
So you segregate them.
Yes. Then you now identify, okay, which part of the northeast is coming with this? Like when we, I think what stood out then was bladder cancer, which is actually going low. We realized that we have a very high incidence in the northwest, Zamfara, Kebbi, and Sokoto. And when we realized, when we dug deeper, we now realize that there are some social activity that these people are doing. Fadama farming, they work, and the career of that is a snail that they can get, that carries the agents, So if you are working in that moody, Fadama farming, usually you put your head without boots, without any protection, you put it there. It can, when you have a cut, it can now stick and then goes in, and then it get implanted in the bladder. And because of that frequent friction, rubbing, that laying eggs and so many other things, then subsequently later in years, 10, 20 years, it will now turn into.
So that research revealed that?
Yes. So that investigation revealed that. So what we did is that because it has some certain symptoms, signs and symptoms that presents early, But in some communities, it has been translated as a mature sign of maturity, that if you are urinating and you see blood coming out, this guy is coming off it. Is a sign that there is something irritating, most likely the X of those pathogen that causes cancer. So we upgrade the level of education of those front-line healthcare workers in primary healthcare of those areas to tell them that please, anybody that comes doing this, these are the likely things. This is what you are advised to do, referral. So we train them, and we provided a channel for referral from that center to general hospital, and to general hospital to the nearest teaching hospital in Nidvi, where he can get an assessment by urologist to say, okay, use this medication, this and that, and even sometimes. So that we actually started, and we are happy with the turnout and so many other. We are not going to relent. The emphasis that we are currently giving is on the 5 common cancers. Not all cancers are preventable, So, can be screened. So, but the 5 most common in the country, those are the ones that we are currently targeting, to see that we bring down the morbidity and mortality. After all, we all know that prevention is far more cheaper and it can far cure as against.
So I can be sure right now that we're doing a lot to make sure that even if you go to the rural areas, they have some awareness as regards what to look out for and how to guide possible patients who come in.
Yes. So currently, that is what we are doing.
Now, we've tried to a large extent to look at some of the steps, prevention, screening. I want us to now look at the issue of addressing those who need care, who have gone through the screening, who have now discovered they have to do treatment or manage treatment. And, how are we addressing that in the country?
Okay. So generally, cancer patients are accessing care in our hospital, majorly by paying from their own pockets. It's quite challenging, funding cancer care, not only in Nigeria, but wherever you go in this country, in the world, is expensive. So it's actually sad. It was out of that we reached out to my minister, Prof. Alipati, and Dr. Isiaq Salako to discuss modalities on how can we support these people. And maybe if you are aware, as of last year, there was a kind of access programs that were initiated by the federal government to see how they are under NICRAD, most of them, that is my agency, to see how we can support, generally cancer patient. There is what we call the Catastrophic Health Fund.
Okay.
So the Catastrophic Health Fund lies in the National Health Insurance Scheme. Now it is a kind of healthcare financing model that supports those with catastrophic disease, with I think, yes, cancer, kidney disease, and heart problems usually. So what it does is, if you are enrolled, covered by NHIS, you can access your care about chemotherapy, radiotherapy, and even diagnostics at half or even less than that the cost of if you are not enrolled.
That exists now.
It exists. It existed. We started it last year. It's under the National Health Insurance Agency. It's just that, people are not aware. And many are not enrolled.
Oh, yeah, okay. Yeah. Into the scheme.
Yes. The current DG is actually doing very well, because I think he has raised the enrollment level by almost, there are about 2 million plus have enrolled since he got into office. So that is very good. So if you can get yourself enrolled and ask whichever center is offering these services, if you are under a TED, you can walk and then get that access. Now, realizing that not many people are enrolled on the NHIE, and there are some that are not working and cannot get themselves enrolled, the federal government or the Federal Ministry of Health and Social Welfare under the federal government established the National Cancer Health Fund.
National Cancer
Health Fund.
Okay.
And this National Cancer Health Fund is domiciled in the NICRAT, my agency, national. So what we do, it is actually a platform that has been piloted, in 6 cancer centers of excellence, and it's still running. So because the seed money we had then was small, so we piloted with 3 common cancers: breast, cervical, and prostate. Anybody that presented with these 3 diseases, you will pass through some, stages. One, because the Cancer Health Fund is purely meant for the indigent, who are not enrolled on NHIS. And they do not NHIS, and do not have the money
to seek care.
Yeah, to seek care. So, and we have some, check and balances. We have to requirements. We have to be sure that you fulfill all these requirements. So when you go, you have to first be diagnosed. Yeah, you have cancer. You be passed to MDT, where we have the social worker, the experts, to make sure that, yes, of course you have the cancer and you cannot pay for the required services. Yes. From there, now it's computer-based.
Yes.
So those that fulfill those requirements will now be sent to the CMD, and the CMD will now pass it and then send to our agency. We have a secretariat for National Cancer Health. The coordinator will look and review and say that this passes and then send to me. I will finalize, and then the money, they have e-wallet, what we call e-wallet, and that e-wallet can be funded, and that indigent patient can access treatment from these cancer centers of excellence. These are currently running to bring down, the burden of the cost of accessing cancer care in the country.
Now, you've spoken about the cost, which is lovely. In terms of facilities, do we have enough in the country?
So generally, we do not have, let's say, enough. But then we are currently improving from where we used to be. When I came into office, I knew we had only 4 radiotherapy machines, what we call LINAC, in the whole of Nigeria. But talking today, they are about up to 14. And then that we had 4, hardly will you find 2 working.
When you say we, are you talking of government?
The country,
private?
the whole country.
Okay, the whole country.
The whole
That's
country. Private and
government.
And government.
Okay.
So, but currently, the country has 14.
Okay.
Of recent, you saw my minister, Prof. Ali Muhammad Fatih, and the Minister of Finance and Information launching new cancer centers, in the country, upgrading those cancer centers with new linear accelerators, to be able to confer the needed care that we are having. So we are not there yet, but at least the current government is changing the tune to actually a better one that will serve our cancer patients.
I would like to talk to you about the issue of standards. I have a personal, personal encounter through a family friend. And I can't remember which test was done, but it was a test to check for cancer. He had presented ill health. And when they checked, the test results said they could not see any indication. But upon further check, outside the country, it was now revealed that that same test was not, the reading may have been erroneous. And where he had been given a clean bill of, no, you have nothing to worry about, they said, no, it still shows. in terms of standards, you know, sometimes in medicine, the testing is, you do the test. But if the results now says there's nothing, when there's something, it creates another problem. What are we doing in that regard?
So it's actually quite true, and it's because of that, you know, my agency has a directorate, what we call a clinical service, that directorate. Currently, what we are doing is to upgrade, you know, the standard of our health care providers, healthcare workers in cancer space. So you see, all this requires human capacity.
Yes.
You have to train your staff. Training, not one-off, but, you know, a continuous webinars, trainings. Yeah, they are not only one. You know, cancer requires multidisciplinary team approach. So you have to train your pathologists to ensure that they are updated with the current knowledge to be able to detect, you know, cancers. You have to train your surgeons to be able to confer the latest surgery on the common cancers that we currently have in the country. The oncologists to prescribe and administer the required chemotherapy treatments and use radiation therapy, you know, to treat. All these ones require continuous spending, you know, investment. And in my agency, we've trained since inception, we've trained more than 1,400, you know, healthcare workers, various levels, on how to, you know, improve and upgrade their knowledges. Second one, you have to support with infrastructure. Okay. You have to provide the latest, you know, equipment, because there are more equipments that are coming in the country. Of recent, my agency was opportune to secure a budget line, you know, from the federal government to upgrade some labs within the tertiary. I think 6 labs, which we upgraded. You know, we procured some needed equipment. We first carried out a need assessment. Yes. What do you have? What are you lacking? And we got, you know, a submission. And based on that, we requested the government that this social centers, and the government answered. So they gave the money, and then we actually buy some equipment to these centers. And I believe, you know, gradually by doing that, you have a good human resource with a good supply of infrastructure, will be able to make diagnosis as when due. And
make them as correct and ensure that as correct
yes,
as possible.
So that's why I said we need to continue.
Do we have enough manpower for this fight, Wayne?
We actually don't. We actually don't, because of so many factors. You know, this JAPA is one of the things that actually contribute. But I'm very happy to say that, you see, we have the colleges that are entrusted with the responsibility of producing more qualified, you know, specialists to treat cancer, are doing wonderfully well. We engage them. I think it's good to say the former State Minister for Health, Dr. Tunja Alausa. We had a meeting between me, him, and the registrar of the National Postgraduate Medical College, the then registrar, on the need that look at what we have, at the number of oncologists, and then even the nuclear physician is going down. How can we upgrade it? How can we have them? Then there was no faculty for clinical oncologists in the country, but I'm happy to announce, with that, you know, discussion that we have, currently we have a faculty for clinical radiation and clinical oncology, with a specialists, you know, that are well trained in to treat cancer with radiation and chemotherapy. We have a faculty, so we can be producing, you know, continuously, you know, a large number of experts, you know, from that area. We also have a faculty for nuclear physicians and molecular imaging. That training, before you have to send a person to South Africa to get that training. But fortunately, we were able to get that. So West Africa too, the West African College of Surgeons too, we've reached out to them, and during the last their AGM in Kumasi, they have approved the faculty status to those clinical oncology. So you can see more are going to. But the only thing is that, it requires a lot of money to train them. But we are making a good progress.
Okay, you remember when you were talking earlier, I said I was going to come back to something. There was a way you presented the picture of our service infrastructure. It sounded really lovely. It was almost ideal. It was almost perfect. And I said I was going to come back to it because, part of what our own challenge is sometimes the gaps between primary, secondary, before we even get to tertiary. And sometimes it creates a problem. I'm happy to hear you said you've seemed to have gotten a network whereby there's a reporting system that will help in your own research. But when it comes to the issue of drugs, we're trying to get people to do screening. We're trying to get them to the hospitals. How are we when it comes to drugs and all the needed?
So drugs, that too, we started talking about access programs that we have in the country. The institute, under the Federal Ministry of Health, established that access program. So we have what we call chemotherapy cancer access partnership program, NCAP, National Cancer Access Partnership Program. This program is helping the country, very well. I think even yesterday I got a call from somebody, a colleague that has a prostate cancer patient that requires certain drugs. I think he went to a farmer and it was mind-blowing. They are about the Zytiga, they call it abiraterone. The drug was they said you have to pay like 1,000, 1.7, something about 1.8 million. And he called me, a very senior, that I learned that you people are running these programs, NCAP program. How can you help my patient? I said, what happened? He said he went to
the pharmacy,
and this is what I said. What is the name? Send me the name of it. And he sent everything. As where is he? He is in Lagos. Then we sent him to our center, NCAP, one of our NCAP center, because we have centers under that NCAP. And he got it at 1.2 something. So NCAP program is actually an MOU that the institute now signed with some pharma companies that are producing these cancer drugs. We assist them in waiving some levies, like custom, taxation and whatever, in collaboration with NAFDAC and custom and some other agencies. And in return, they subsidize the drugs. So we are winning. Now, we are getting two very important things. One, the drug is gone down to almost 50% of the cost in most of the drugs that we have. And the second, we are getting good drugs. We are sure of the quality of that. The drugs that we are getting from the company are actually the ones that are getting to us. So, and we are continuing to expand. I cannot, I've forgotten the exact number, but we are expanding that NCAP to virtually cover all the hospitals that are offering some chemotherapy services, to cancer patients in the country. We started with 6. I knew of a time where we were 18. I know now currently we are 24.
How do people who need to get the service, how do they know where to go to?
So if they go to the teaching hospitals, mainly where we are offering radiotherapy, chemotherapy service, they should ask that they want to go to an NCAP. Yes, they have their oncology pharmacists. Wherever you go in those centers of excellence or where we offer those cancer services, there are dedicated cancer pharmacists.
And there are checks to ensure people don't go there, buy it to go and resell it for Because
you have to come with prescription.
Okay.
Yes, we cannot, we cannot completely.
I appreciate. It's just that, sometimes when there is some measures taken, people sometimes take advantage of it.
I understand. So what we are doing, we only sell on prescription. You have to present your prescription. And in most cases, you see that these pharmacies are very close to the oncology department. So we know almost virtually who operates and who does what.
Okay, Prof, my time is running out, but I would like, from your perspective, you have like a bird's eye view of where we are. You understand what government is doing, and I want to know where you think we are going. Because there are people who are out there in Nigeria who, from those who are worried this could be something they might have to deal with. There are also those who are already addressing this sort of challenges. What does the next 2-3 years look like for you, and what are you trying to achieve as soon as possible to help address what is clearly a very major problem?
Okay. So there are so many things that we are currently doing, but the most important is the one that we started with. Treating cancer or managing cancer is expensive, most especially when it is at an advanced stage. So to avoid that, another important point is that prevention is very cheap, and it offers an opportunity for cure.
And for the 5 you say are prevalent here,
yes,
there are screening that can be done?
Yes, there are some screening modalities that can be. So it was out of that the National Institute for Cancer Research and Treatment, that is NICRAT, now review our strategy, because we have a directorate for cancer prevention and control, that if the whole Africa and Nigeria also are having issues, regarding raising enough money to be able to treat and procure all this big equipment, why can't we channel the little budget that we have into prevention, which is cheaper and confers cure? So, and that is why we opened this NICRAT, the National Initiative on Cancer Early Detection, Treatment and Network Care. So we are going computer-based. Roche has also come in to support us. So we linked our community-based, engagement that we are currently doing. American Association of Cancer Research, AACR, also collaborated with us. We started with Abuja. We were like in 6 or 7 regions in Abuja doing, health talks, health education, and then doing some screening program, and then referring
people
them. Yes, because one of our center that we have for this night scan is Jabi, Paramedical Center Jabi. We have a center where you can go beautifully well equipped with a mammography machine, a colposcopy, and those equipments that you can do prostate and so many other things. So those that we give health talks to, we refer them to Jabi to get all those screening programs. So those that we, and virtually all their details are recorded, where they are from and whatever. Once your result is ready, we'll give you a call. That, okay, so we've done this, it's negative. Or, okay, sorry, we've done this and we've discovered this, then you require a further intervention.
And this where you can go.
Yes, then we confer the intervention. If it is something that requires surgery, it can be operated. Or if it is something that requires radiotherapy, and then we can refer you. So we are trying, currently we are trying with, we want to thank Roche for what they are doing. They are collaborating closely with us to see that we finish the development of this model. Once we have it, it's going to be linked virtually to all the regions. And we have a very robust navigation system from community, to a screening, then to the point of care.
So this point you just made, is it that the centers, people are going around or people can come to you?
We are,
Or they're in the federal medical centers?
They're in the federal medical centers and teaching hospitals.
So people can go in there.
People can go. People can go. We provided the equipment. The federal government provided the equipment.
Okay. Prof, I would like to thank you so much. I know if we keep on talking, there's a lot we can talk about, especially to address the concerns of a lot of Nigerians who are out there and who need help. But we'll keep watch with you to see how you develop and how much work we can do. Thank you so much for spending time.
Thank you for having me.
Great.
Thank you.
It's encouraging to hear of the efforts the federal government is making on this matter, but it's equally important for state governments to take decisive steps because this is one area where every hand must be on deck. As my guest rightly noted also, we can take advantage of existing initiatives designed to support citizens who are going through this issue. I'd like to hear from you. Please share your views with us through our social media platforms and the email address on your screen. And if you'd like to catch up on past episodes, simply search Newsnight on the Channels TV YouTube channel and then click on the playlist and then take your pick. That's it from us tonight. I'm Lanre Lasisi. Thank you for watching and please enjoy the rest of your day. Goodbye.